Hello, welcome to Pathogonia. This is Jay. Today we're going to talk about interesting cyto cases. First, we have pleural fluid, peritoneal fluid, and pericardial fluid. What will you see in cyto specimens? You'll see your normal components include mesos, histiocytes, and lymphocytes. Here in this patient with a 70-something-year-old patient with a history of some sort of B-cell lymphoma, they had some pleural effusions. So from here, we see a scattering of very small cells with some histiocytes that I could appreciate on low power. But these cells, I'm not sure if they're red blood cells or lymphocytes. So closer up, we see hyperchromatic cells that are fairly uniform with this thin rim of cytoplasm, more consistent with lymphocytes as opposed to red blood cells. And then you have some eosinophils as well as your macrophage. This is just another photo of the same specimen with your lymphocytes here, histiocytes here. This is a cell block, and it shows you that these are indeed lymphocytes. So if you're concerned, you can send for flow just to make sure it's reactive or monoclonal, to rule out monoclonal. So this was a CD3 that was done on the cell block, and as you can see, all the reactive lymphocytes are T cells. And there's one study, or just wanted to mention, reactive lymphocytes in pleural effusions are generally T cells, in particular CD4 cells. This was a PAX5, and as you can see, it's negative. And this is why it's important to know the staining pattern, whether it's membranous, cytoplasmic, or nuclear, because PAX5 is nuclear for lymphocytes. And although there is some blush, this isn't staining nuclear, so this was ultimately called negative. Ascites. Again, we'll see mesos, histiocytes, lymphs. So this is a 70-year-old patient with bloody ascites with a concerning mass in the colorectal region. So they did a washing in the peritoneum, and from the get-go, you can see these clusters of 3D cohesive groups with this kind of stringy acellular material that kind of reminds you of mucin. So as we look closer, we have these single malignant appearing cells. I mean, histiocytes are pretty large in itself, but this is even much larger. You can fit 10 lymphocytes in this monster of a cell with this high NC ratio, hyperchromaticity. So here's a PAP that corresponds to one of those 3D structures. You have these hyperchromaticity, but the biggest sign I look for is this nuclear pooching, where the nuclei come to kind of pooch out of the cell, which you don't really see with reactive mesothelial cells, which can look really funny. Here's a corresponding cell block to one of those 3D structures. This was a Mach 31. So this confirms that these cells are epithelial. This was a calretinin, and this confirms that this is not a mesothelial. SATB2 was done, and it was negative. However, CDX2 was positive. So this was favored to be cancer cells from his colorectal carcinoma. So why is the CDX2 positive but the SATB2 is negative? SATB2 should stain GI origin, especially colorectal. One study by Ramos et al. In 2019 found that 98% of conventional adenocarcinoma of the colon is positive for SATB2, but 83% of the mucinous colorectal carcinoma is negative. So if you are thinking that there's a mucinous component, it might be worth ordering the CDX2 over the SATB2 if you had to choose one. So this is a 80-year-old patient with an increasing peripheral lung lesion. So from here, we can see cohesive groups of cells with some scattering of some other groups of cells. Let's take a closer look. Here we have this community border. We have high NC ratio. We have some of these cells kind of pooching out. They have delicate Well, let's look at the PAP to better appreciate the nuclear features. They have some nucleoli. They're kind of granular, and they can have like an eccentric nucleus as well. So this is the cell block, and it has a vague glandular pattern, in my opinion. Also a vague glandular pattern, just kind of closer up. This is TTF1 napsin. In our institution, napsin is cytoplasmic and it's red, and TTF1 is nuclear for the lung. So this was adenocarcinoma. Again, TTF1 can stain normal pneumocytes, so you want to be careful for TTF1 that has entrapped pneumocytes that look angulated but are just normal pneumocytes. Next case, we have an 80-year-old with a central lung mass that has been increasing in size over the past couple of months. So we get an FNA of the lung. We see of the lung mass. We see cohesive groups here, 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 here. One of those cohesive groups, we see maybe a histiocyte here, but we see these interspersed large cells with a central nucleus with dense cytoplasm that is cyanophilic in color, or robin's egg blue in color. They're polygonal, they're well-defined borders, and so here's a corresponding PAP where we can see some orangiophilia corresponding to some keratinization. So this is good for, as you probably have guessed, this is the cell block for squamous cell carcinoma. And you would be right, P40 is nuclear positive, as you can see here. Now let's talk about this case, an 80-year-old gentleman with a mass in the central portion of the lung encasing his bronchus. We see this cohesive groups with some discohesive cells. Closer up, you see some molding. The cells themselves have high NC ratio, very delicate cytoplasm. They have these blue bodies called paranuclear blue bodies, and some lymphoglandular bodies as well. On PAP, where we can better visualize nuclear details, it has this salt and pepper kind of chromatin, and here is the cell block. We do an INSM1, it is nuclear, it is positive, and then we do a cytokeratin, and that's positive as well. This is a 50-year-old woman with a central lung mass as well. We can kind of see this cohesive group with some, maybe a little bit of discohesion here. Closer up, unlike your prior small cell carcinoma, these cells have more cytoplasm. They have eccentric nuclei, kind of plasmacytoid. They don't have a relatively high NC ratio for some of them, like this one, but this one has a really high NC ratio. What of note, they have these prominent nucleoli, kind of looks like a cookie here. There is some molding as well. And here in the cell block, you have some rosette-like structures or nested architecture as well. Here, INSM1 is positive, nuclear, and your cytokeratin is positive. So this was good for large cell carcinoma. Of note, neuroendocrine carcinomas are made up by small cell carcinoma, large cell carcinoma. Genetically, they oftentimes have a p53 retinoblastoma 1 inactivation. Neuroendocrine tumors, on the other hand, in the lungs are carcinoids and atypical carcinoids, and they don't have that p53 retinoblastoma 1 inactivation. Well, thank you so much for watching, and we'll see you next time on the next episode of Pathogonia. Bye.